KSOMP conference I've missed. I was down with COVID then when Jubin organized. So it's almost after 2 years I'm seeing you all. And I would like to thank Dr. Sunil and team for this wonderful platform which is given to us. And today I'll be sharing with you some of the interesting cases which we had. Some of the cases we had a real tough time diagnosing, and we literally had to break our head to come out with an accurate diagnosis. So diagnosis, as you all know, is a very tedious process which involves a systematic approach. The entire process involved in the process of diagnosis can be summarized under 6 C's. When you come across a case, when a patient comes to you, for example, with a swelling of maxilla or mandible, first thing what we do is we try to bring in all possible lesions which mimic this particular lesion, right? So we try to bring in all lesions which present as a swelling of the mandible or a swelling of the maxilla. Then we try to classify them. Then we try to compare between the lesion to come out with a clinical diagnosis. Once a clinical diagnosis is made, we go in for investigative techniques like imaging studies, and final confirmation is made based on the microscopic examination of the biopsy tissue. And the final diagnosis, of course, depends upon the microscopic analysis. And this is where exactly our role comes into picture. So last set of players to arrive at, mostly we turn out to be the game changers to help the clinician in deciding what treatment need to be given for that particular case. So we hardly get into touch with the patient. Our communication is through the clinician. Clinicians provide us with a bunch of differential diagnoses, and it becomes our responsibility to pick up the right apple from the basket which is provided. Sometimes we do pick up apple which are lying outside the basket too. One of the biggest challenge we face in diagnosing oral lesions by microscopic examination is that we are just provided with a small bit of tissue in the form of incisional biopsy, and probably we get a brief summary of the clinical aspects also in the form of request form. And from that small biopsy specimen, that too we take a section of 4 micron thickness, and from that small piece of tissue, we need to diagnose a lesion which is quite huge. That is, the histological findings which we see need to be extrapolated to a tumor which is quite large. This is a very difficult task, very challenging task. And the translation of histopathological features into an accurate diagnosis requires conversion of multiple sections viewed in 2 dimensions into a tumor which is in 3 dimensions. Unless you have a good idea about how a tomato looks like, you won't be able to diagnose or identify tomato from the section. That is, you should have a clear picture about the clinical background of the lesion to come out with an accurate diagnosis. So this is what exactly we do in our PG training. During the postgraduate training, we get to see the cases. And it's very important that the postgraduate students start learning of seeing the cases. They should see the cases clinically, then correlated with the histology section. Only if you learn that way, once you start practicing pathology, you can do it in the reverse order. That is, when you see the sections, you will be able to reconstruct mentally the clinical presentation of a lesion. So can you diagnose this case? This is something like a spot diagnosis. You can put it in the chat box if you have an answer. So it's a papillary lesion, right? Which is occurring in the palate. It's a case of inflammatory papillary hyperplasia. When I see a lesion like this, I always remember bitter gourd with all those elevations and bumps. So you'll be really amused to see the resemblance between the sections. Right? You can see that elevations over here. It's matching exactly with that. The way we diagnose a case, like we do the microscopic diagnosis, can be compared to the Google Lens. I hope all of you use this Google Lens, right? So when you want to identify a bird or animal or a or a plant or a place, what we do, we just we provide the image, and the Google matches the image with the images which has already been stored, and they come out with a proper identification. And this is exactly how we also work. We have images of all those lesions which are filed up in our memory. We have separate file for odontogenic lesions. We have separate file for salivary gland tumors. We have separate file for epithelial tumors, etc. And what we need is we need to know how to pick up the right file and the right image, right? So your skill as a pathologist depends upon how good you can interpret a slide, how well you can correlate with the clinical features, and also on the number of images which has been saved in your memory, whether the images are stored in kilobytes, megabytes, or terabytes. All this finally affect the outcome. So with this background, let's see some cases now. It is going to be something like a hands-on, not exactly hands-on, it's eyes-on, right? Eyes-on experience for you. So we'll see the first case. This patient was a 36-year-old female patient who presented with a swelling involving the right side of the mandible. This patient actually is known to me. She's my friend's relative. And she had the swelling for around 1 year. She resides in Delhi, and she has already shown a hospital in Delhi. And when she came in, she brought with her the images. Let's see the images now. This was the OPG of the case. Okay, so you can see a destructive lesion involving the mandible and the periapical region of the premolars and molars. It is well defined, and you can see that there's resorption of the roots here. Okay, roots are resorbed, and probably you can also see some ossification over here. It could be the bone septa which is left behind, or some calcification too. This is the CT image. Here you can see that the labial cortex is completely gone and lingual cortex is thinned out. And the 3D reconstruction showed that it was a through and through lesion. The buccal bone is completely gone and the lingual bone perforation is also there. So she came with the provisional diagnosis of odontogenic keratosis. Of course, it could be odontogenic keratosis, but you know that odontogenic keratosis grows in an antero-posterior direction. So only after considerable amount of mandible is lost, you'll have this perforation. Okay, here for a small lesion, relatively small lesion, bicortical perforation is they're suggesting that this could be a more aggressive lesion. So we also added a few differential diagnoses like ameloblastoma, which is more common, COT and COC was included because we were able to see some opacification in the radiograph. Now the surgeons, when they opened up, they felt that it is a cystic lesion, there was a cavity. And they were going with the diagnosis of odontogenic keratosis, and they gave us 5 bits of a soft tissue for microscopic examination. So now let's have a look at the slides. So going with the clinical impression, it was initial slides were showing a picture of a cystic lesion. You can make out the epithelial lining over here, and this is the peripheral bone. The higher power again showed the epithelial lining, and there were a few islands within the connective tissue stroma. You can see the islands in the connective tissue stroma. But the other slides which we saw, here again, odontogenic, it looks like odontogenic epithelial islands. The other slides which showed proper tumor. Okay, you can see that there's sheets of epithelial cells. It's not very clear under this power. Maybe we, under high magnification, you'll be able to make out. And there were ductal spaces. Can you make out the ductal spaces all around? Higher magnification, we found that these ductal spaces were lined by small cuboidal cells or low columnar cells. Can see some secretory product also within the ductal space. And one corner of the tumor, we are able to see a lining epithelium, which is cuboidal or columnar. The ductal spaces. Again, you can see the ductal spaces, small and large ductal spaces here. And the tumor proper was composed of epithelial cell, polygonal epithelial cell with centrally placed nuclei, and the cytoplasm was granular. So we're looking at a tumor with granular cells composed predominantly of granular cell and adenoid component, the ductal component. Any guesses? We are suspecting a odontogenic tumor, but we're not able to see any odontogenic epithelium over here. But focally, somehow we managed to see one area which appeared that it could be odontogenic, because most of the cells were polyhedral and eosinophilic, but focally we could see some tall columnar cells, and maybe we can think that it is showing reversal of polarity also. So that was the only area where we could think of an odontogenic lesion from the histopathology. So putting together all this, we thought of these differential diagnoses being showing the ductal pattern, or adenoid pattern. We considered salivary gland neoplasm. Among the salivary gland neoplasm, oncocytoma and oncocytic carcinoma are the most likely diagnosis here, because we are seeing oncocytic cells, granular cells. But again, this was intraosseous in location, and intraosseous oncocytoma is very rare, and oncocytomas are generally seen in parotid glands, not even in minor salivary glands. So we ruled out that. The other possibilities are metastatic adenocarcinoma, most likely from thyroid. Thyroid carcinomas, both follicular and papillary carcinomas, can show granular cells which resemble this. Then possibility of ameloblastoma, because focally we are able to see that ameloblast-like cells. And since we are seeing the granular component, it could be granular cell ameloblastoma. So now the important task before us is that we need to rule out metastatic adenocarcinoma. So how do we go about? We need to rule out metastatic adenocarcinoma. The options are, you can go for a PET scan, or you can go for an IHC, or both. Okay. In this case, when we tried with IHC initially, the tissue was not immunoreactive. So we just dropped it over there, and we thought, the problem with IHC is that it will be very difficult to find out the primary. You need to decide on the panel, and it takes a lot of time. And the patient was also young, and we just wanted to do it fast. So we went ahead with PET scan, and the PET scan report came as no other area showed any tumor. It was what we're seeing in the mandible was the primary tumor. Then we did IHC specifically for pancytokeratin, which was positive. P63, because this is a very sensitive marker for odontogenic epithelium. So it's not specific, but a very sensitive marker. All odontogenic lesions will be positive for P63. So this was positive. And again, granular cell ameloblastoma, the epithelial cells with granular cytoplasm will be positive. So we could get focal positivity for CD68. So putting together all those, we decided to diagnose this as granular cell ameloblastoma, adenoid variant, because we're able to see some adenoid areas within the some areas. So the surgeons, based on this diagnosis, they went ahead with a resection, and we got the mandibulectomy specimen. This is the submandibular salivary gland, which was removed along with that. Now, have a look at the microscopy of the excisional specimen. The whole lesion was seen as a epithelial tumor mass. You can see the periphery, the connective tissue stroma. The connective tissue stroma was evident only here, and probably in some areas in between. Because otherwise, it was something like looking at an AOT or something, where you see the tumor mass as a whole. And whatever appeared like ductal areas in the incisional biopsy seemed to be pseudoductal spaces, and we are able to make out the connective tissue stroma in between here. And otherwise, predominant ductal component was not seen in this particular, the excisional biopsy specimen. So the tumor cells were composed of granular cells, as with the incisional biopsy specimen, and large polygonal cells with centrally placed nucleus, some of them eccentrically placed. And you can make out the granularity of the cytoplasm. Again, some ductal spaces. This is in fact a pseudoduct. And probably in this section, you can make out the granular cytoplasm. Now, at the periphery of the lesion, we could see that there were islands which are infiltrating into the adjacent areas, and in the form of clear cells, and also as epithelial nest and cords. Again, most of the areas did not show any signs of odontogenic epithelium. Probably here it looked like a dental lamina in some areas. Towards the periphery of the lesion, we were able to see in some areas the tall columnar cells and this much of stellate reticulum. And here in the connective tissue also, this was resembling the ameloblastoma. You can in fact see the inductive changes also here. And the peripheral reactive bone to be seen here. Now, this is the tissue decalcified bone, which is adjacent to the tumor margin, showed proper ameloblastomatous islands, confirming the diagnosis of ameloblastoma. You could see another slide also here. The typical ameloblastoma was seen, the bony, adjacent bony margin, but the resection margin was free of tumor. So the final diagnosis was given as granular cell ameloblastoma. The problem which we had with this case was because usually we see granular ameloblastoma like this within the follicles, ameloblastomatous follicle, we'll see more eosinophilic granular cells. But in this case, the whole tumor mass was composed of, it was occurring as an epithelial mass and it was composed of granular cells. And following resection, reconstruction was done, and now the patient is quite happy, and she's waiting for an implant to be placed, and she has sent me this photograph recently. So that was the first case. Now this is for the postgraduate students. Can you guess the pathology from this image? What does it remind you of when you see this? Like to write in the chat box? We would like to provide it in the chat box. You can do that. Chat 6, let me check. Nobody? No. Nobody. Probably next image will, sorry. So this is cystic lesion, right? When you can relate it to a cyst. Okay, this is how usually the cysts look like, the luminal space and the connective tissue capsule, and this will be the epithelial site. And when in the case of most of the cysts look like that, but there are cysts which gives that scalloped outline. OKC. When I think of OKC, I think of the section of capsicum. And probably you will be able to relate this neural thickening which causes the scalloping of the borders. Now, let's move on to the case number 2. Here, I don't have the clinical photograph. This patient, a 60-year-old male patient, presented with a diffuse swelling on the right side of the lower jaw, which was of 3 months duration, associated with intermittent pain. And intraoral examination revealed a swelling in the anterior region of the mandible. It was quite extensive, extending from the right mandibular canine 4-3 to 3-1. So look at the OPG. It was very similar to the previous case. You can see that there's a well-defined radiolucent lesion with some sort of opacity over here, and that there is a resorption of the root also. And you can see that this is acid-filled. The CBCT showed that the buccal bone is completely gone, and there is lingual perforation here. And this is a 3D reconstruction image showing the through and through lesion. Clinically, it resembles very much like the previous case. And these were the differential diagnosis which we gave, because the tooth has undergone RCT, so we thought it could be a radicular cyst also. And among these differential diagnoses, we thought calcifying odontogenic cyst could be the most likely, because it's located in the anterior region and it is locally aggressive, and we are able to see some opacification also. So the surgeons, when they approached the lesion, they found that it's a cystic lesion, and they completely enucleated and gave us the lesion as a whole. And it was in fact a cystic lesion showing irregular luminal space and outer smooth surface. Okay. And look at the histopathology. Of course, it was going with the clinical diagnosis. It was a cystic lesion. There was a cystic epithelial lining. And this cystic epithelial lining is odontogenic in nature. You can make out the tall columnar cells and reversal of polarity. But the connective tissue stroma, the capsule, showed the neoplastic component. We could see the odontogenic epithelial sheets and islands within the capsule. And you could also see the inductive changes in the periphery, the junction of the epithelium and connective tissue. We could see the inductive changes. There were ameloblastoma epithelium predominantly. You can make out the tall columnar cells and showing reversal of polarity and stellate reticulum-like areas. Then there were epithelial whorls which were distributed throughout, something like the epithelial whorls you get in AOT. So many areas showed this. And there were also spaces, ductal spaces, quite a lot of ductal spaces like this. And these duct again seem to be a pseudoduct for us because within the ductal spaces, we're able to see a vessel, sometimes having RBCs also. You could see the mesenchymal tissue. So most likely all these ductal spaces could be a pseudoduct, not a true duct. We were able to see ghost cells. You can see the eosinophilic cells with faint outline of the nucleus. Some of these ghost cells showed the calcifications too. Inductive changes were visible. You can make out the dentinoid material which has been formed. Again, the inductive changes, and you can see the cells which are getting entrapped within the dentinoid material which has been formed. Here there are clear cells, islands of clear cells entrapped here. And this slide, last slide, is quite interesting in that along with the dentinoid formation, we were able to see proper dentine. Can you make out the tubules here? Dentinal tubules. It was going in for a proper dentine formation over here. So the possible diagnosis which we thought was unicystic ameloblastoma, possible ameloblastoma, but not fitting exactly into the features. Calcifying odontogenic cyst, it was a cystic lesion but had neoplastic component. Dentinogenic ghost cell tumor, of course, as per the WHO recent classification, dentinogenic ghost cell tumor is described as a tumor, not a cystic lesion. So how do you name a cystic lesion with neoplastic component? It was a bit confusing. That's when we came across a lesion which has been termed as adenoid ameloblastoma, which is considered as a variant of ameloblastoma. Around 40 cases had been reported, and most of the lesions presented as unilocular radiolucent lesion, and the gross finding in most of the cases was cystic. And looking at the microscopic appearance, the diagnosis of adenoid ameloblastoma demands the presence of a constellation of features like ductal areas, epithelial whorls, ghost cells, clear cells, and dentinoid. And the recent WHO 2022 includes this tumor under an epithelial neoplasm, and it's defined as an epithelial neoplasm which is characterized by cribriform architecture and duct-like structures with dentinoid being often present. So in our case, we are able to see ameloblastomatous component, the ductal areas, the epithelial nodules, ghost cells, clear cells, dentinoid, and even dentine. So based on this, we gave the final diagnosis of adenoid ameloblastoma with dentinoid formation. Now, this is for the PGs. Any guesses? Cauliflower-like growth. Any guesses? Chat box, let me check. No one? Yes, it's there somebody. No one yet. Okay, fine. So that is a case of squamous papilloma. Squamous papilloma. So look at the similarity in their sections. Now let's move on to case 3. This patient, a 60-year-old female patient, presented with a diffuse swelling on the lower jaw, which was of 1 month duration. There was again pain associated with the swelling. And the imaging studies revealed a very similar lesion like the previous two, where there's a destructive lesion involving the mandible. Here you can make out the perforation of the lingual cortex, and here in the reconstructed image, you can see that there's perforation of the buccal cortex also. So it could be any aggressive odontogenic cyst or aggressive odontogenic tumor. So the initial diagnosis, clinical diagnosis, was a cyst. So they aspirated, and this is what we got. There were cells, quite huge cells, large cells with vesicular vesicular cytoplasm. And it was something like looking like a mucinophage or a macrophage, but quite large, big. It was looking like an epithelial cell, quite large cells. Now, this is the gross specimen. They enucleated the whole cystic lesion and provided us the gross specimen. You can see that the luminal side, there are quite a lot of nodular swellings. Now, have a look at the histopathology. It was a cystic lesion. You can see a cystic lumen and epithelial lining. And there were cells which resemble ghost cells, eosinophilic cells with a faint outline of the nuclei. And as with the previous case, here also we were able to see the neoplastic component within the fibrous connective tissue wall. Can see the islet which is undergoing cystic degeneration. Quite a lot of epithelial islands were distributed throughout, and you can also see inductive changes. Very much similar to the previous case which we have seen. Probably this epithelium is very clear. This is an ordinogenic epithelium showing tall columnar cells, showing reversal of polarity, stellate reticulum-like cells, the presence of ghost cells. These are the ghost cells. And in the connective tissue stroma, you can see numerous islands of ordinogenic epithelium, some of them giving the typical ameloblastoma-like picture. And you can also see the dentinoid which has been formed here. This is the cystic area. One of the island was showing a cystic change. And what was interesting here was that the cyst was, the epithelial cells were undergoing degenerative changes, and we could see proper granular cells which are just protruding out into the cystic lumen. And probably this is what exactly we saw in the FNAC. These cells, these granular cells, probably when they aspirated, these cells also would have been there in the cystic space. So you can see the dentinoid formation, inductive changes. The ameloblastomatous follicle with typical tall columnar cells and reversal of polarity. Ghost cells were seen in the connective tissue as well. You can make out the ghost cells which are seen in the connective tissue. And this is dentinoid again. And ghost cells were seen entrapped within the dentinoid material, probably undergoing some sort of apoptosis or some degenerative changes. And we are able to see the clear cells also getting entrapped within the dentinoid matrix. So again, this was a cystic lesion with a neoplastic component. There were no epithelial nodules or whorls to name it as adenoid ameloblastoma. And we didn't have any other option than give a diagnosis of dentinogenic ghost cell tumor. In the WHO classification, they purely say that dentinogenic ghost cell tumor is a neoplasm, and we do not know how to name a cystic neoplasm where you get the neoplastic component in the cystic wall. But Reichardt describes this sort of lesion, cystic neoplasm, under dentinogenic ghost cell tumor. So that was the diagnosis which we gave. Now this is for PGs, spot diagnosis. It is verruca vulgaris. So it again resembles resembles your papilloma. But I won't like to relate it with cauliflower. Rather, I would like to relate it with broccoli. Look at this section. Look at the similarities. Now, case number 4. This patient, a 70-year-old male patient, came with a complaint of a swelling involving the lower jaw, which was present for a duration of around 1 month, and there was pain associated with the swelling. This was the intraoral picture. And look at the radiograph. This was a proper multilocular lesion. You can see an impacted tooth also over here. And here you're getting that typical honeycomb pattern. Typical honeycomb pattern. The diagnosis which we gave, differential diagnosis which we gave, were ameloblastoma and odontogenic myxoma. Now look at the microscopic presentation. Can you give a diagnosis? Can you attempt a diagnosis? This is very typical, very typical. You are seeing epithelial islands, and these epithelial cells are eosinophilic. And you can also see that there are some structure here, globular hyalinized masses, right? So what is diagnosis? Obviously, it has to be CEOT, but calcification was very minimal. Only these are the two areas where we could see the calcification. There was minimal calcification. Only two areas we could see the calcification, and you can see the least gangrene here. And we did special stains. There were clear cells within the epithelial component, but these clear cells were negative for PAS, and the amyloid-like material was positive for Congo red, and it showed apple green birefringence. Now we wanted to find out what these clear cells are. They are not cells which are filled with glycogen. Then what it could be? So we went ahead with CD1A, which is a marker for Langerhans cells, and these cells were positive for Langerhans cells. So there were quite a lot of Langerhans cells here. So ultimately, we gave a diagnosis of calcifying epithelial odontogenic tumor, but there's a variant termed as non-calcifying Langerhans cell rich variant, and this was one such variant. This tumor, this variant is said to be more aggressive than the conventional variant, and also this is more common in elderly people. So can you guess the pathology now? Does it resemble any histopathology you are familiar with? Any guesses? So its section resembles Wathin's tumor a lot. Now let's go to the case 5. That's the last case. This patient, a 58-year-old female patient, presented with swelling involving the right side of the maxilla. You can see a slight bulge over here. This was the intraoral finding. So the radiograph showed a lytic lesion involving the maxilla. You can see that there's lytic lesion here, and this is involving the sinus completely. Okay, you can see the floor of the sinus is completely gone. This is a destructive lesion involving the maxilla. So this was a histopathology. Here you can see an atrophic epithelium, a thin atrophic epithelium, and a tumor which is underlying within the connective tissue. It was a well demarcated tumor. You can see a normal looking connective tissue here. And the tumor tissue was composed of lobules of clear cells separated by fibrous septa. So when you see a picture like this, you have quite a big list of differential diagnoses to consider. So among the odontogenic tumors, there's clear cell variant of COT and also clear cell odontogenic carcinoma. And sometimes squamous cell carcinoma can show similar picture. A clear cell variant of squamous cell carcinoma shows very similar picture. Melanoma can present as clear cell tumor. Salivary gland tumors like mucoepidermoid carcinoma and hyalonizing clear cell carcinoma can present with a very similar picture. And also metastatic tumor, that's renal cell carcinoma. Now, we did special stain to rule out some of these lesions. CEOT was ruled out because even though eosinophilic areas were seen, it was negative for Congo red. Mucicarmin was negative, ruling out mucoepidermoid carcinoma. Then melanoma was also ruled out because its tumor cells were negative for HMB45, the melanocytic marker HMB45. Then the possibility of hyalonizing clear cell carcinoma was considered, but here the hyalonized areas were very minimal, were seen only focally, and the cells, where tumor cells were PAS negative. The tumor cells in hyalonizing carcinoma will be PAS positive. Here it was PAS negative. And since tumor cells were negative, we also ruled out renal cell carcinoma, which usually show PAS positive glycogen-rich clear cells. And also, in the case of renal cell carcinoma, we see quite a lot of hemorrhagic areas and sinusoid vasculature that was missing in this histopathology. So what was left behind was clear cell odontogenic carcinoma and clear cell variant of squamous cell carcinoma. So now we did immunohistochemistry, and the tumor cells were positive for PAM cytokeratin 19, and EMA suggesting that the tumor is epithelial in origin. We never had a doubt about it. But cytokeratin 19 was done thinking that that will help us to differentiate between clear cell odontogenic carcinoma and clear cell variant of squamous cell carcinoma. But then we realized cytokeratin 19 can be positive even in squamous cell carcinoma, so you cannot use it for differentiating these two. So one option for us was to use P63. P63 is positive in clear cell odonogenic carcinomas. All clear cell odonogenic carcinomas are positive. Even squamous cell carcinoma can be positive, but it turned out to be helpful for us because P63 was negative. So since P63 was negative, it was more likely that it could be a squamous cell carcinoma. Not all squamous cell carcinoma will be positive for P63, whereas a clear cell odonogenic carcinoma will be positive for P63. It was negative, suggesting that it could be a squamous cell carcinoma. Another option before us was to do in situ hybridization for looking for this mutation, genetic mutation, but it was a little bit expensive and we didn't go for that. And what was left with us was only the paraffin block and HNE, hepatoxylin and HNE stain. So we decided to fall back on the traditional way, the traditional HNE staining. So we went for deeper and deeper sections. And till we saw something like this, where we could demonstrate the superficial epithelium, which is dysplastic, and where proper invasion was noticed. And the lesion was diagnosed as squamous cell carcinoma, clear cell variant. So this is now for PGs. Whenever I cut spring onion, I think of this lesion. Any idea what it could be? Where you get tubules which are cut in cross section. Look at the resemblance. It could be hemangioma or any other vascular tumors, vessel-rich vascular tumor like a vascular malformation. This is just for you to get the concept about the tumor as a whole. Now, I had actually, in my presentation, I had focused on odonogenic tumors, but I didn't want to reveal it in the beginning because I wanted you to have a open thinking to diagnose each and every case. Odontogenic tumors are a rare heterogeneous group of tumors derived from various components of the tooth-forming apparatus. And the component of the odontogenic apparatus which contribute to the development and the degree of differentiation they undergo during the process decide the diverse histopathological features. Most of the cases we'll be able to diagnose. Most of the cases will appear like how the textbook pictures are, but sometimes you can have a problem when the microscopic features do not fit exactly into the histological description, or when there's a overlap of features between the tumors. Now, histopathological diagnosis is not all about matching the images. It's something more than that. Your knowledge regarding the tumor as a whole, the origin of the tumor, the histogenesis, the pathogenesis, the process of evolution, the changes which occur during the evolution of a tumor, the clinical manifestation, all this will help you in arriving at a diagnosis. It's not just about matching images. So what I'm trying to tell you is that an artificial intelligence may not be able to replace the pathologist. Known is a drop, unknown an ocean, but always remember that many a drop makes an ocean. Thank you so much. Thank you all for your patient listening. And once again, I would like to thank the organizers for this platform which is given to us. Thank you. Thank you.